All right. I'm going to go ahead and get started. So welcome, everybody. My name is Andy Ellis. I'm the secretary of the Baltimore City Green Party. And tonight we are excited to have the third in our recurring speaker series that we started in 2021. And tonight we have Dr. Margaret Flowers, who is going to speak to us about fighting for Medicare for all during the Biden era. Before we do that, I want to turn it over to Andrew for just a second to give us an update on the tech that we're going to be using tonight and how you all can interact with this. Andrew, go ahead.
Hi, everyone. My name is Andrew. I'm a member of the Baltimore City Green Party. And so for today, you'll see that we have both the chat and the Q&A functions enabled. So at any time, feel free to put comments in the chat, whether if you agree with something, you really like something that's said, feel free to use the chat for that. But if you have a question that you would like answered on this live, then you should put that in the Q&A section. And then that way we have those all in one place. And so they don't get cluttered up too much in the chat because we don't want to miss any of your questions. So make sure to use the Q&A function.
Great, thank you, Andrew. And we have Ashley, who's going to be working the chat for us tonight. And Ashley will make sure that any questions that come in the chat get directed to the Q&A. If you see Ashley in the chat there, just say hi to her. She's on our team as well, but she's working in the background tonight. And then at the end of this, so we're going to do a presentation that Dr. Flowers is going to go through, and then we will have plenty of time for Q&A at the end. So this is going to go till 8:30 Eastern, and we will have probably up to 45 minutes or more of Q&A. This is streaming live on our Facebook, and it will be available on our YouTube afterwards for sharing. And so with that, let's get into tonight's presentation. Margaret, you want to take it?
Sure. Thank you, Andy. And thank you, everyone, for being here and for Ashley and Andrew providing tech support tonight. So I was asked to talk about kind of advocating for Medicare for all during the Biden era, and also what is the green vision for healthcare in the United States. And I'm just going to present some basics, but I think mostly what I want to do is get into what your questions are and get into a discussion with everyone. So, if there was ever a time in the history of the United States when we should be putting in place a national improved Medicare for all healthcare system, this is that time. With the pandemic, we've seen just the complete failure of our healthcare system and how the disparities that exist have been exacerbated by the pandemic. We have a recession where we don't have the current uninsured numbers right now, but coming into this last year, 2020, coming into it, we had about 30 million people in the United States who had no health insurance. And we know that millions, if not tens of millions of people have lost their health insurance as they lost their jobs. So I anticipate that we're going to be seeing some pretty high numbers when the census number comes out in September of uninsured people in the United States. And then we just have really a growing support for national improved Medicare for all. We have a higher number kind of across the political spectrum of people that are in support of it, but we particularly see even people who are registered as Republican voters, an increased number of people who are supporting national improved Medicare for all. And if you look at kind of different movements out there and when they put out their platforms, what they include in it, we see that there's just a much broader kind of base now of people supporting a national improved Medicare for all. So all of that is really good, and it gives us, an environment in which to advocate for this. But I think it's really important for us to recognize that while, there are Democrats who have run on national improved Medicare for all, who are co-sponsoring the legislation, the reality is, and I've spent a lot of time in Congress, and I've spent a lot of time, talking to members of Congress and just watching their behavior. And the reality is that, they sign on to it because it's something that's popular with their base. If you look at Democratic Party voters, it's like 85, 90% support for national improved Medicare for all. But they are not, Democratic politicians are really not doing much at all to either advocate for this or, push it within the Congress. So, we don't see them putting statements on their website of support. We don't see them really talking about it out in public. And we certainly don't see them pushing the leadership to move this along. So I think it's important for us to recognize where they are, because kind of throughout the last couple of decades in the US, what we see is that Democrats will sign on to it and push it when they don't think it's going to go anywhere. But if, things start to move, or if the environment comes into place where it actually might pass, we see them, back away from it. This is what's happened at the state level, around the US. So, so it's interesting that, Joe Biden campaigned on opposing national improved Medicare for all. He literally said that if it comes to my desk, I won't sign it. So we don't have kind of that, like there's no friendship, there's no love there from the Democrats for this policy position. But when we're looking at a policy that would basically challenge a huge industry in the United States, the medical industrial complex, and we look at having two major parties in power that are capitalist parties, it's no surprise that they're not, coming out full support for national improved Medicare for all. Now, does that mean that we can't win it? Absolutely not, because, any gains that we've made throughout history in the United States, have gone against the interests of these, capitalist parties that we're talking about, winning working rights for workers, or, I think of during the Nixon era, where there was a really broad movement of labor and environmentalists who actually won establishing the Environmental Protection Agency, the OSHA, as well. So these were policies that the leadership didn't support, but because of the social movement, they were forced to do that. And I think that having the pandemic and economic crisis, having the public support gives us the environment that if we organize and take advantage of this moment, we could really push this forward. And I think, potentially win it. I do want to talk a little bit about the recent American Rescue Plan, because there were some health provisions in that, and it was basically considered, a big expansion of the Affordable Care Act. But this actually takes us farther away from having a national improved Medicare for all system, because it gives more money and more power to the private health insurance industry. I wrote an article about this for Truth Out maybe a month ago, and I found that there was a letter sent to the White House by the health insurance companies, their lobby groups, the Chamber of Commerce, business groups like that, and basically everything that they asked for, they got in the American Rescue Plan. So the government is now giving greater subsidies so people can, if they lose their insurance through their employer and they want to stay on it through the COBRA system, there's more money for that. But that means money that's directly going to the health insurance corporations, is not going to people. They also expanded the subsidies for purchasing health insurance. Again, that all goes directly to the health insurance corporations. But we know that in the United States, even when people have private health insurance, it doesn't mean that they can afford to get the health care that they need, because most of our plans are ones that have high out-of-pocket costs, high deductibles, or high copays. So people pay their insurance premium, but then to actually have their insurance work, they have to pay these copays and meet their deductibles, which are often thousands of dollars before those benefits even kick in. So we have a large population of people that are underinsured. They have health insurance, but they still can't afford to get the health care they need. Or because of the way these plans are structured with their narrow networks, if someone has an accident and they go to a hospital and they're seen in an emergency room that's not in their network, they're then responsible for the full payment, of that. And it's a very complicated kind of system, but it's really, skewed towards making money for the insurance companies and, putting in place structures that shift more and more of the cost to the individual person. So, so the ACA is a system that's built on that. It's really just built on private health insurance. And then since the passage of the ACA, we've seen more and more privatization of our public insurances, Medicare and Medicaid, so that they basically the major insurance companies are now getting more than 50% of their revenue from the government, whether it's through these subsidies that help people buy health insurance or through basically providing these public insurances of Medicare and Medicaid. And so this is just adding this huge cost to our system, you know, all this money that's going to the private insurance companies, and very little of that is being returned to the people in the form of care. So it's a huge ripoff, and you know, that's why we need to get rid of the system. We're the only industrialized, wealthy country that has a system like this, where healthcare is kind of a financial instrument to make profit for these corporations, and really health is not the bottom line or a priority really in any way. So so you know, the facts are on our side in terms of, you know, our system is not working, it's very complicated, it's very expensive, we're losing our health professionals, our health outcomes are not that great. And the solution is obvious. If you look around the world and look at the healthcare systems that other countries have, or even just looking at our own systems within the United States, we know that having a system that everybody is in, that's publicly financed, that is publicly run, is a much more efficient system. It you know, leads to higher quality care. We can provide more benefits, and you know, we can really make health the bottom line of what, you know, what our system is. And I just experienced this. I was in Nicaragua. I just got back Sunday, and I got very sick while I was down there. Our whole team got sick, but they just, you know, were like, "Do you want to see a doctor?" And I'm like, "Well," and they're like, "Well, yeah, we'll send a doctor and a nurse to your room." And they did, and they literally just treated me in my room. Nurse stayed with me, took care of me, and gave me medicine, and it did cost me nothing. And that's just how the healthcare system is, and you know, in a lot of countries, it's there for people when they need it, and it's provided. It's not something that you have to pay out of pocket for, at least, you know, at the time of care. So what is the green vision for healthcare? If you look at the howiehawkins.us website, I think that's the best place to see a really fleshed out vision of what a green healthcare system could look like. I mean, the platform of the Green Party for decades, I mean, Ralph Nader ran on this in 2000, has been for a national improved Medicare for all system. But with Howie Hawkins, he and I co-wrote the policy paper for that, and really kind of spelled out exactly what it would look like. So I can put the link to that in the chat when we're doing the Q&A. But basically, the very first step is to move to a national improved Medicare for all. And national is important because we want a healthcare system where every single person living in the United States can get the healthcare that they need. And we know that if we had a state-based system, like our Medicaid system, that there would be some states that have good systems and some states that have poor systems. And that's not what we're looking for. We're looking for every person being able to get the care that they need. Plus, it's just needs to be done at the national level, because at the state level, states have a fixed budget. And so, you know, if you have a portion of your population that has very high healthcare needs, that's going to be putting a strain on the health budget and mean that there'll have to be cuts made elsewhere. But with the federal government, we don't have to worry about that. The federal government can because it'll be a huge national pool, it'll be able to cover the healthcare costs, you know, of everyone. And also because the federal government can run a deficit as well. So we're looking for a national improved Medicare for all, where every single person is in the system from the time they're born until the time that they die. It's financed through our current healthcare spending, which is almost 70% public dollars going into healthcare at this point, and then meeting that rest of that 30%, or if we won't even need to do 30% because we know that if we had a national improved Medicare for all, it's actually going to cost less than what we're paying right now. But meeting that extra cost through a progressive tax, and one that really doesn't put the burden on people, like people at the lower end of the income spectrum shouldn't be paying anything into the system for their health care. So making it a progressive system, a progressively financed system, making it purely public. There shouldn't be any role for making a profit in our healthcare system. And this is one area where the legislation in Congress that's been introduced, Pramila Jayapal is a representative from Washington State who has reintroduced this year a Medicare for All bill. It's HR 1976. And she doesn't ban the for-profits. And that's problematic because basically if you tell the for-profits, as the bill does, okay, now to be in the system, you can no longer make a profit, they're just going to be like, okay, we're going to sell our facility for condos or retail space or something like that. They're not, we already see that happening. We see it happening in cities where the communities are gentrifying, and these long-standing hospitals that served poor communities are now being turned into condominiums and retail space and things like that. So really important that the whole system is a not-for-profit system. Under National Improved Medicare for All, the benefits should be completely comprehensive so that nobody needs any kind of supplemental insurance. And this means getting away from our current practice, which is what I call body part medicine, where insurance companies will say, oh, well, we'll cover, this and this, but we won't cover your vision or your dental or your hearing or your mental health or things like that, or reproductive services. So people are whole people, our bodies are all one, and we need to have everything covered that we could possibly need. And giving people full choice of where to go. Right now there's so many restrictions in the current system. You have to find somebody that's in your network. And so if in the new system, if you like your health professional, you can stay with them. If you don't, you can change. If you have a new problem that arises and you need to see a specialty center or a specialist outside of your area, you can go there. You can go anywhere within the United States and the territories for the care that you need. And also it's really important to have a healthcare system that's integrated with our public health. It makes no sense that we have a public health system in the US and then we have a health delivery system, public-private health delivery system, and there's no real connection between them. And that's been a really big problem during the pandemic in terms of coordinating care, coordinating and prioritizing, where we put our resources, making sure that people who test positive for COVID are informed and given the information that they need to prevent spreading it to other people, and being given the things that they need so that they can quarantine and not spread it to other people. There's been a real failure of that because those systems aren't integrated in the US. And then, so kind of the first step is to expand Medicare to everyone with comprehensive benefits. But then beyond that, and this is kind of outlined in the plan that Howie and I wrote, is really moving towards a fully public system, and and turning it more over to community control. So making sure that people who live in a community have an input into what services are provided and how ththose services are delivered, because there are variations in needs for different communities in the United States. And so when people say, oh, well, Medicare for all it can't be a one size fits all, it can be a democratically, have democratic participation in it, so that each area does, try to meet the needs of its local population. And one of the real benefits of a National Improved Medicare for All is that it actually provides us with a system. So we don't have a healthcare system right now. We can't look at all of our health data. Like people literally can't get access to all of our health data to understand like where we have, areas of concern, where do we not have services? Where do we have certain health conditions that maybe we need to look at a more preventative approach? This would create a system where we have that data. And what a lot of countries do that have a national improved Medicare for all system is they look at that and they set priorities each year, and they say, you know, these are kind of our top problems that we need to use a public health approach to address these and try to reduce these, you know, health conditions in our population. So, so that's a big plus of having a national improved Medicare for all. So what can we do as, you know, as the Green Party? Well, I think we play a critical role. I think the Green Party has played a critical role in putting single payer national improved Medicare for all on the political agenda, you know, just as we've done with the Green New Deal and other issues. And so we are not tied to the Democratic Party. We are able to critique, you know, what they're putting forward, to be honest about it, to kind of hold the bar of this is what we're fighting for, this is why we're fighting for it. So so running on it is really important, advocating for it, teaching about it, doing outreach, using it, you know, as an opportunity to reach out to more organizations and groups and people in our communities to say, hey, this is what we're advocating for and what we're fighting for, and this is why, and, you know, we'd like you to do that with us. And then, you know, just applying pressure. We need to be thinking about ways that we can make this issue more visible and putting pressure on the, you know, members of Congress to press them to be more active on this issue. You know, folks need to be watchdogging really the members of Congress and saying, hey, you know, like, you signed onto this bill, but you're not even talking about it. You know, why aren't you talking about it? And right now in Maryland, so the only bill that we have in Congress is this HR 1976, and it's like, it's pretty good. It has a couple weaknesses, but overall it's pretty good. It has 113 co-sponsors, and out of Maryland, 3 of our members, Anthony Brown, John Sarbanes, and Jamie Raskin, have signed on to it. The other members have not. And out of those, I would say John Sarbanes, we've been working with for like a decade now on this, and so he actually has a pretty good understanding of the legislation, although he's not, unfortunately, he's not treating this as a top priority issue and advocating for it in a big way, although he's done some things. He has done some, you know, spoken on panels and things, very few, but that's better than a lot of members of Congress. But anyway, yeah, so we just need to be, you know, educating, reaching out and building the kind of groundswell, and then really putting pressure, doing the things that we need to do to, you know, call out our lawmakers, bird dogging them, protesting them, those kinds of things to get this really moving. So I'll stop there. And what I really want to do is get to your questions. And I think, Andy, you all had a few questions to start out with. So why don't we move to that?
Great. Thank you, Margaret. I really appreciate that overview of it. So folks, if you have questions, please put them in the Q&A and we'll make sure we get them to Margaret. I wanted to start out with one question about state programs. So it seems like in Maryland and in other places, there's been a push to bring this at a state level. And you mentioned it a little bit during the talk, but can you talk about the drawbacks of both the strategy and the policy of trying to do this, or trying to advocate this at a state level?
Yeah, so a couple of things to think about there. I mean, one is that this is what Nancy Pelosi has really been pushing. She's been telling everybody, oh, just go do it in the states first. You know, you should do it there and see if it works before we do this in Congress. And that's because they don't want to pass this in Congress. They would rather that people just go out and fight at the state level for this. And so we have to recognize that it's the Democratic Party strategy. People will argue, oh, well, didn't Canada start out by passing it in a province first? And we can be like Canada, and if one of our states passes this, then it will, become a national system. And I think that it's really important to understand that Canada in the 1960s, there was a lot of kind of experimentation going on with socialized systems, and they actually had a completely socialized hospital care. So they had a federal system for inpatient care that covered hospital care. And so Manitoba was the first province to then do a whole system at the provincial level. But it was shortly after that it was actually a conservative cabinet member that looked at the system and said, oh, this just makes more sense. From a financial standpoint, we should do this in the whole nation. So I don't think that we can expect that same kind of thing to happen in the United States. And also, people have been trying for decades at the state level. And the reality is that you can't do a pure single payer system at the state. And that's why it always kind of falls apart, because when it comes down to it and you look at like, oh, what would this actually look like? That's when you realize that it's not possible. So I mentioned the financing. That's a huge part of why you can't do it at the state level, because it will really put a huge strain on state budgets, and they'll end up having to cut something. And usually in the past, when they've approached these kind of universal systems, they've never actually achieved the goals they wanted to achieve, and it eventually fell apart due to the finances. But there's, if you think about it, our healthcare system is very complicated right now. So for a state to try to create a whole single system, you run into barriers of, Medicare. You can't force seniors to choose your state Medicare because they have a choice of different Medicare plans by law. You can't force federal employees. Federal employees have, choice of their different federal health insurance plans. So you can't force them into it. You can't even force businesses into it. There's a law called ERISA, the Employment and Retirement something Security Act. And basically, ERISA tells states that they have no power over health insurance plans, employer health insurance plans. And in fact, there have been some challenges to that legally over the last decade or so, and all of those challenges have made it more clear that states have literally no control over the employer health insurance plans, not even able to get the data from them. There was a court case of that in Vermont where they just wanted to get the utilization data, and the court said, no, you can't have anything, any information about this. So there are all these kind of barriers that means that states can't really have a single system with everybody in it. And that the only way you get the most cost savings is to have a single system with everybody in it. And then on top of that, the financial barriers. And then on top of that, just as I said, we don't want a state by state system, because we're going to end up with superior and inferior systems. And we know that traditionally in the United States, the states that will have the most regressive systems are going to be the ones in the South. And so if we have a federal system, we can make sure that everyone everywhere is getting that high quality system. So I think those are kind of the main thing. Oh, also just the one other thing is the way that the state legislation is written, even if it was passed in a state, there would be a lot of work to do to try to implement it for a long time. And I think that is just going to suck a tremendous amount of energy into focusing on individual states and take it away from that national fight. So the only way we're going to win the national improved Medicare for all is if we say, this is what we're fighting for, and then we organize and win it. And I think the state efforts really detract from that.
Great. Thank you, Margaret. Let's start going to some of the questions from the Q&A, and I'll start with one that is, under the Hawkins Flowers plan, are doctors and nurses considered federal employees? Same question for the Jayapal bill, HR 1976.
Yeah, so the way that it would work kind of under both is that if a physician works for like a hospital or some sort of a facility, they would be salaried by that facility. And then the role that the federal government plays is it would give an operating budget to that facility. So a global budget. It would include both the costs for operating the facility as well as a separate budget for any kind of capital expansions or big equipment or things that they need to buy. So they would be employees of that facility. If someone is in like an individual practice, then they would just build a system just like, we would do right now for Medicare or Medicaid. So it's not like they would like be in employment. They would still have an employee, they would still have autonomy, but they would be paid, through the system, if that makes sense.
Great, thank you. Next question is, are you familiar with Britain's NHS? How would your proposed system differ from theirs?
So yeah, I am familiar with the National Hospital Service. It is a true single payer system. The government owns the facilities, the workers are government employees, and it's very much like the VA system that we have here in the United States. That's also a socialized single payer healthcare system, although it's an underfunded one, as is the NHS. The NHS has really been under attack since the Thatcher years, and there've been, pushes to underfund and privatize that. The Hawkins plan starts with National Improved Medicare for All, because that's something that we can do very quickly and very easily. Every health professional in the country that's practicing has a national provider identification number so that they can be billed through Medicare. So we already have that infrastructure to be able to, to pay the health professionals. So moving quickly to get everybody into the Medicare, making it more comprehensive, getting rid of the out-of-pocket costs so that people can just go and get care when they need it. And then under the Hawkins system, we do want to move towards a more of an NHS-like system, because that's the most efficient type of system, is when you have a true public system, the whole system is completely public.
Excellent. The next question is, how does your National Improved Medicare for All program deal with legal status issues? Would it be threatened by massive influxes of immigration?
Well, so no, I mean, we're bordered by two countries that have national health systems. Mexico and Canada already have their own systems, and they work quite well. And even, a lot of the Central American countries, like I said, I was just in Nicaragua, and they have, an excellent healthcare system down there that, people actually come there, to get care. So, would there be some people coming to the US for care? Possibly, but I don't think it's going to be, massive numbers of people, or we don't really have that great of a healthcare system right now, to be honest. And there's a lot of work that needs to be done to improve our healthcare system and improve the way that people view the healthcare system in the United States and use it. So I don't think that's going to be a big issue. With the way that the Hawkins plan is written, and the I don't know that the Jayapal, they haven't put out the text yet of the bill. It was just introduced recently, but in the previous version, I believe that it left the definition of resident up to the Secretary of Health. So, the government could say that you need to live here for a certain period of time. That's what some countries do. They may say that, like, you have to live there for between 2 and 6 months before you're in the system. But what that does exclude is emergency care. So if you're in the country and you need emergency care, or you're pregnant and you're going to deliver a baby, then that's covered. But some countries do say you have to live there for a certain time before you get the other services. I think it's really important that every single person living in the country gets care. That's the best for all of us. If you think about it, particularly with infectious diseases, we're a lot better off if everyone who thinks that they're sick can go and get evaluated and get the treatment that they need. And just our communities are better. I mean, are we really going to, like, our next door neighbor be like, well, yeah, we know you have asthma, but you're just, sorry, maybe you can't work because you've got asthma and it's not being treated, or you can't take care of your kids because of that. We're not going to give you care. That just doesn't make any sense in communities, that we would allow our neighbors to, not be able to have a health so that they can do the things that they need to do.
Excellent. Next question is, how would Medicare for All impact people with rarer conditions?
Well, it would take away the financial insecurity that they have. I mean, it would mean that, they would be able to get the care that they need. And, right now, the way that one of the things that came out of the Affordable Care Act in 2010 is, you hear so much about how insurance companies can no longer exclude people with pre-existing conditions. And so what the insurance companies did as their workaround, because they always work around every regulation so that they can protect their profits, that's their responsibility. They created what are called narrow and ultra narrow networks. And so they exclude a lot of like major health centers, because they know that when people have serious problems, that's where they go for care, and they don't want to have to pay for that care. So so this would end that. People could go, if there's a specialty center somewhere in the United States that is focused on the particular condition that you have, you can go there and get the care you need, and it's going to be covered. What we advocate for in the Hawkins legislation, which is very similar to what the French system does, is, this is really about putting control of healthcare decisions back into the hands of patients and health professionals. Because my experience when I was practicing, and I mean, this is a common experience by pretty much every doctor in the US, is that you have the insurance companies are the ones that are practicing the medicine. They're telling you, what you can have for your patients and what you can't have, and you have to fight with them. This would take that away, so that it's really health professionals and patients talking together about what's going to be the best treatment plan for that person, and then they can get it. And so if there's something that falls out of kind of the standard situation, the way they deal with that in France is that the health professional then presents their plan to a group of people that are in the same area of expertise. So it's not an insurance administrator, it's people that have that knowledge. Maybe it's a pulmonary doctor, a lung doctor, or a heart doctor, or kidney doctors, and you present it to them and you say, hey, this is what I'm thinking, this is best for this patient, and they can review it, maybe even give you advice, and then you can render that treatment. So it would be better, I think, for people with rare conditions. I know just one anecdote, a friend of mine whose son was living in Australia, the son had a particular type of cancer and was scheduled for surgery, and the health system came back and actually said, hey, we don't want you to get that surgery. We want you to go to this better facility and get this more expensive surgery because it has a better outcome. And that's what a healthcare system is supposed to do. It's supposed to be looking at like what's going to give us the best health outcome, because in the long run, that's usually going to end up saving you, money anyway. Yeah.
Excellent. Are the barriers you mentioned to state-based Medicare for All present at the federal level, or does federal legislation overcome those barriers?
So federal legislation could overcome those barriers. The one thing that I think is really concerning is giving a waiver for Medicare. So, we have two fairly good systems in the United States, which is the VA system, although it's not fully funded, but it is, more efficient, and docs in the VA system can really just focus on their patients' healthcare needs. And then the traditional Medicare system, which has really lifted seniors out of poverty. It's improved their health outcomes. We see health disparities start to disappear once people turn 65 and go into the Medicare system. And if we open that up and give waivers to a state to, dismantle these systems, basically like to have all their Medicare dollars, that's going to start eroding that Medicare system. And it's also going to open a door so that, the one state could say, well, we want our Medicare dollars because we're going to try to do a single payer system or a universal system. Another state could say, we want our Medicare dollars because we're going to do a waiver or voucher type of system. And so you lose that control, and we could start seeing just a real, destroying of our Medicare, of our traditional Medicare under that.
Next question. Are there significant differences between HR 1384 and HR 1976 that you are aware of?
Yeah. So like I said, the text of the 1976, I haven't had a chance to see it. It's not posted up on the Library of Congress website yet. But what I've heard through kind of the single payer channels is that there's not really very significant differences between the two. There's just been a little bit of, tweaking here and there. So, so I don't think it's substantially different.
Great. Next one is, how would this plan deal with existing medical debt and pending lawsuits against people who have outstanding debt?
Good question. I just, I quickly wanted to make, now it's gone out of my head. There's one other point I wanted to make about the state stuff, but, oh, I know what it was. So there is, I think Ro Khanna introduced this bill that would get rid of it would give waivers to states so that they wouldn't have, and I think it would get rid of the ERISA or change the ERISA law as well, so that states could try to do a universal system. But I've always thought, like, to pass anything in Congress takes a lot of organizing and mobilizing to make that happen. And so why would we fight for this bill to give states waivers so like a few states could get a single payer system instead of really just focusing on getting national improved Medicare for all for everyone? That just never made sense to me, that people would like go off on that tangent and kind of take that circular route. Can you ask me the question again? The medical debt is about medical debt.
Sure. How would the plan deal with existing medical debt and pending lawsuits against people who have outstanding debt?
Yeah, I haven't seen anything in the law that would address that. So that's a really good question. But I think that under the new system, it wouldn't really make that much sense to pursue that, because each health facility is going to be getting the financing that, the funding that it needs to operate, going forward. And health professionals are going to be, paid for the services that they render, which is different than the way it is right now. I can tell you, you have to fight to get paid for the services you render. In systems that have, and even in our own Medicare, health professionals get, they get paid without too much hassle and fairly quickly. So I would probably advocate for just erasing it and saying, going forward, the system's going to pay for what we need.
So yeah, I think that's an interesting point, because so many people in the current system, in the current broken system, have a bunch of medical debt, and a crippling amount of medical debt that stops them from being able to either get medical care or to live a life that's not paying back the medical. So you just say, just wipe it out and stop hospitals from being able to go after it?
Well, they wouldn't. In the new system, there wouldn't be medical debt, because people wouldn't be paying up front for care. It's so much more efficient if we just put our money into creating a system, because the biggest cost of a healthcare system is the facilities, the brick and mortar facilities, paying the staff, paying for the supplies that you need. And and once you have the facility there, then people can go and use it. They just get the care. It's a different way of financing healthcare than what we do right now, which is where we charge for every little thing. I mean, literally in the hospital, they have to keep track of like every pill that's delivered, every like syringe, every IV bag, and then we bill based on all these little things. It's a micromanaging a system in a way that's really inefficient and takes away from being able to just spend time with patients or focus on, caring for the patient. So this would be a different way of doing things.
Excellent. There's a few more questions about policy, and then I want to shift to the politics a little bit and to figure out how we fight to win for this, because it's a good plan and it's not passing. So we need to discuss how we get from here to there. But there's a few more policy questions that I want to ask. One is, so who gets to decide what care gets provided? We've seen recently in Arkansas that they're banning certain medical practices to be given to youth who are transgender. And we also know that there's constantly a fight at the federal level about abortion. In this case, would the United States federal government get to decide which procedures were eligible to be practiced by doctors around the country?
So the way the legislation is written, the federal government lays out what's covered in general. So inpatient care, outpatient care, visits to the doctor, long-term care, rehabilitative care, substance abuse, mental abuse, medications, medical equipment. That's what it says in the bill that's covered. But it's the health professionals and the patients that make the decisions. You're in the hospital for whatever and you're getting treated for whatever. That's not the federal government saying, what you can and can't have. That's inpatient care is covered. If you're in the hospital, your care is covered. So also, we don't have control over that right now with the private insurance companies. I mean, literally, even services that are supposed to be covered by insurance companies, they'll just routinely deny them and know that people may not know that that's covered or not. If the insurance company says, denied, then that means people have to go back and read the plan and figure out, is it, covered? And a lot of people just don't do that. A lot of people just don't fight it. But even in Maryland, there was an audit of the health insurance companies, I think it was in 2004, and they found that Blue Cross Blue Shield just would routinely take 1 out of every 5 claim that was a valid claim and just toss it in the trash. And also there was a state senator, I think it was, who got turned down for something, and it was something that was in her plan. The insurance company just turned it down, and that kind of exposed that practice as well. So with a public system, and especially as we move towards community control over the system, there are ways we actually have a mechanism to say, we want this in our healthcare system. And I think one thing that's a really important concept with National Improved Medicare for All is that, there's a saying that a system for the poor people is a poor system. And that's because, a lot of people, unfortunately, just don't care about the welfare of poor people. And so, it's like, oh, well, I've got a good plan, so I'm okay. And I don't think about my poor neighbors and whether they're getting what they need. If everybody's in the same system, it raises the bar for everyone because we all have a stake. This is our system, whether you're rich or poor, you're in it, and the politicians are in it, everybody's in it. And so we all have a stake in making this a top quality system for all of us, and a mechanism, because it's a public system, to fight for that. Excellent.
Does the AMA support HR 1976? Why or why not?
So the AMA, the American Medical Association, is like a trade organization for physicians. And I think it's important to know that it's a minority of physicians that belong to the American Medical Association. I think it's been in decline, and I think, when I looked about a decade ago, it was about 15% of practicing physicians belong to the AMA. I never belonged to the AMA. It's an institution that cares about protecting the financial bottom line of physicians and isn't like that concerned about health overall. But there has been a lot of work by people to push on the AMA and also to push on other health associations like the American Academy of Family Physicians and the American Academy of Pediatrics. And what was the one that, there was an internal medicine group that recently came out in favor of a single payer system. And there've been protests at the AMA calling them out for not supporting National Improved Medicare for All. So I don't think of them as an institution that really cares about people's health, but there are, docs that are taking steps to pressure them to come on board.
Wonderful. Very good answer. There are 2 questions here about preventive care. What about preventive care, and will it take a greater role in the Green Improved Medicare for All?
Yeah, well, the Green Improved Medicare for All basically calls for creating a commission to look at our health our health needs, our health outcomes, and come up with plans to address those. So it really is looking at kind of a systemic level, like what do we need to change in order to improve our health outcomes. And like I said, other countries do that. I know New Zealand sets every year 5 priorities, health priorities. So that is intervening at the population level to like look at like, why do we have these conditions going on? So that's why it's another point is that when you have a national health system that everybody is in, it starts to impact the other policies as well. If you look at the European Union, one of the reasons that they banned, they don't allow any chemicals into products that are sold on the market unless they've been proven to be safe first. That's the precautionary principle. It's very different from the way things operate in the United States, where corporations can put out whatever the heck they want in, and then people have to prove that they've been poisoned. And a big part of the reason that they did that in the EU is because they have their own national health systems, and they knew there would be savings if they weren't poisoning people, through toxic products. And if you look at where industries locate, close to communities, that would be another thing that we'd have to start looking at. What are the health impacts of doing that? So it does have a whole impact on kind of public policy. And so I think these are kind of preventive kind of things, but also, if we, and there's going to need to be more work to increase our primary care workforce. We really, in the United States, we have kind of the opposite ratios from what are needed to have a good healthcare system. We have like 2-to-1 specialists to primary care, and it should be 2-to-1 primary care to specialists. But ideally, what we want to work towards is having a stronger primary care workforce, so people have a physician, they can stay with that health professional if they like them. They don't have to worry about losing their insurance or their company changing plans, and then they can't stay with the person they like. And so we know that this is better for health. If you have an established relationship with a health professional and they know you, and you can, and they can remind you, hey, you haven't had this, test in a long time, we need to be screening. That will just improve, I think, our preventive care as well.
Okay, excellent. So these are wonderful answers to the policy questions, and I really appreciate the sort of rapid fire nature of the questions and your ability to just sort of handle them as if it's the second nature for you. So I really appreciate that. I want to shift to politics for a little bit and talk about how we win this. So it has often been said, or I've seen a lot of discussion recently about how the left is focusing on the impossible wins instead of the tangible wins. So how do we tangibly organize right here in Baltimore and in Maryland and in our communities in order to move toward this system that you're talking about?
Well, I mean, this needs to be a fight at the national level, but every city, every state can play a role, because if you think about the way kind of movements happen, when folks see something happening in one area and it's starting to get attention, they'll often copy that in their area as well, or get inspired by it. So we could, in Maryland, we could be an example, to the nation of really fighting for national improved Medicare for all. And what it looks like is, widespread education. Like there's still a lot of people that don't know that this is even an option that they should be fighting for. So preparing materials, getting out into communities, meeting with communities, doing presentations. We created, through the Maryland Healthcare is a Human Right campaign, a presentation on racism in healthcare that talks about national improved Medicare for all and how that might start to address some of the issues with systemic racism in our healthcare system. That's a good opening for conversation. We have a really good movie called The Power to Heal that we've showed around the state and had discussions, and that's very inspiring as well in terms of getting people activated. It's about how the civil rights movement won Medicare, and it's a great story, and it was really activists that made that happen. We could be putting pressure on our members of Congress, and in a number of different ways, including bird dogging them, going to their offices, things like that, and just being really persistent and saying, we're in a pandemic and a recession, this should be a top priority right now. I think we have to understand that the power structure is pretty savvy, has a lot of resources, and it's pretty smart. And what it's been able to do is basically convince people that when you're asking for national improved Medicare for all, that you're asking for too much. So I think the biggest hurdle we have is just to keep people focused, because the Democrats are so good at just like taking people off. They did it with the public option. It was masterful in 2009, 2010, the way they split the single payer movement, convinced people that they could get a public option if they fought for it, and that it would be a path to single payer. That was all payer. That was all complete BS. But it succeeded. And in the end, when there was actually momentum building for a public option, the White House pushed back against it and prevented it from being in the final legislation, because it was never meant to be in the final legislation. It was just a distraction technique. So we have to be able to recognize these things. And, you know, just when we're like, the thing with movement is that you never know how close you are to winning. And the more that they push back, I mean, the fact that Biden felt like he had to come out and say, if you put Medicare for all on my desk, I won't sign it, means that he's feeling threatened by the fact that people want Medicare for all. And what that tells us as activists is that's the time to fight harder, because we're getting closer to winning. So, so it really is. It's the basic education, organizing, growing, being visible, doing actions that put pressure. We have to make this like the only solution that we're going to accept, and make it so that it's the only politically acceptable solution for a politician to, you know, be talking about.
Excellent. And another question that stems off of that, and without getting into too much detail, what are some direct actions that can help to push this forward onto the public agenda?
I think when it comes to direct action, you know, we look at like a whole set of issues of, you know, what is going to be an action that is really clearly exposes what the issue is, has, you know, clear messaging about what's going on, that gains attention and sympathy from the community, you know, has a good tone to it, you know, all these things that we think about. And so I think that it really depends on your population and where you are, and what, you know, what you think is going to work for the environment, for whoever your target is. But we've done, back in late 2009, we had a really successful national mobilization against private insurance corporations, where we, you know, we had T-shirts that said, you know, patients over profit, you know, national improved Medicare for all. And people went to insurance companies to expose the fact that they are the problem in our healthcare system. They're not a solution. They actually make our healthcare system worse. And so there were all kinds of sit-ins at these health insurance corporations. One team in Louisville, Kentucky actually even got locked in. Humana locked them in all night without bathrooms or water, you know, and that got a lot of attention. So those kinds of things, I think, bird dogging, you know, your politicians so that everywhere they go, they're hearing about this, is also really effective in, you know, pushing them. And that happened a lot in 2017 after, you know, Trump was inaugurated. There were all these healthcare town halls around the country, and it was amazing to see people in like Oklahoma and other states that we don't think of as being, you know, bastions of Medicare for all support. People, you know, asking their members of Congress, why aren't you supporting this? Why, you know, and, you know, pressuring them. So I think that type of thing is also really important. Yeah, I think that, you know, I kind of, the acronym I came out of after the healthcare fight in 2009, 2010 was ICU, that we need to be independent in terms of not tying our issue to the political agenda of the Democrats or Republicans. We have to be really clear about what we're asking for, because they're going to try to distract us with these public options, or lowering the age of Medicare, or we'll give you this little thing. And we have to say, no, this is our bottom line, national improved Medicare for all, and then being uncompromising, just, you know, not settling for anything less and just being really persistent. And if you do that, that's how we're going to eventually win, because they're going to keep pushing back and try to get us to back down. If we don't back down, we're going to win.
What do you think about the efforts to get cities and states to pass resolutions in favor of improved Medicare for all?
I think that if it's used properly, it's a tool that can be used to build the movement. So I think that if folks are going to try to get a resolution from their city or county council, that it needs to be done by, looking at what are the organizations, groups in your community that might support this, going out to them and using it as a tool to say, hey, we want to get this resolution passed. Can we talk to you about this issue? Would you sign on? So that you're actually building your capacity, you're building your base, and then you take it in, and you get this passed. And then the Howard County folks that got their county council to do a resolution, also their county council wrote a letter to the congressional delegation telling them that they want them to be advocating for this at the national level. So that's another way that it actually is useful to communicate to the congressional, members. So those kinds of things, I think, it is a good tool. It's something we used when we were fighting to stop the Trans-Pacific Partnership. These resolutions were a big part of that, fight as well. And especially when we won them in like places that had relied a lot on trade, like Washington State, we got them passed there. So it can be useful.
I want to remind folks that you can drop questions into the Q&A or into the chat, and we will make sure that Dr. Flowers has an opportunity to answer them. We have about 15 minutes left of Q&A, so please go ahead and drop any of those questions in there if you have them. I have a question. You've been involved in this for a very long time. How do you feel about where the movement is now versus where it has been at different points in the past?
I actually feel really good about it. And I have been doing this for a couple of decades now, and I just see a lot of new energy coming in. I see, like when last year, early on, there was kind of some movement towards calling for a general strike, and one of their, top demands was national improved Medicare for all. When I look at a lot of different groups and how they're kind of putting out their platforms, I see a much broader base of support for national improved Medicare for all. So I do really think when you look at kind of the trajectory of social movements, we're at a place now where, things are in place if we organize, that we could win this, but it's going to take a lot of work. One of the themes that came out during my recent trip to Nicaragua, where we were looking at the revolution down there and, the revolutionary process and how they've won it, how they defended it, how they continue to build it. They talked about revolutionary discipline. You don't win without discipline, without work. And if we put that effort in, we can win.
Question. How do we combat the hospital and insurance associations that have a lot of influence and a lot of money?
Yeah, and in 2009, I think it was like 8 insurance lobbyists per member of Congress, and they were spending about $1 million a day. But we have numbers in terms of people. And I was really inspired during 2009, 2010, in that there was kind of a small group of us without a lot of resources that just thought very strategically about how to put pressure on Congress. And we got very close to having a National Improved Medicare for All resolution introduced on the floor of the House. It got pulled in the last 36 hours. And we did succeed in getting a National Improved Medicare for All. It was actually an amendment to the legislation that would have substituted what Congress was putting together with a National Improved Medicare for All system. It was an 800+ page amendment. And it was direct action by a small group of people that pushed that onto the agenda, where it got to the floor of the Senate. It was withdrawn 3 hours later, but we were successful. So I don't think that we should ever underestimate the power that we can have when we mobilize a small number of people, and how sensitive members of Congress can be to the, you know, actions that we take. I mean, what pushed that onto the floor was kind of like the final straw was we went to the Senate and we made cutouts of dead bodies and wrote the number of people in each state on each one that died because they couldn't have health care. And we had a letter, and we went into the members of Congress's offices. We had media following us, and we put these dead bodies down on the floor, you know, these cutouts on the floor, and, you know, and read our letters. And, you know, staffers were upset by that. Some staffers came out and talked to us about it. It got a lot of attention. And just, you know, yeah, just being creative and persistent.
All right, we have a question from Thomas, who became a Green in 2010 after seeing you speak on this issue. And so Thomas says, shouldn't there be a law that requires the text of the bill to be publicly available when it receives a number?
That would be great. Yeah, there usually is a delay, especially if there's a lot of legislation going on, but it would be nice if we could get a copy as soon as it hits the floor.
So I think this leads me to another question. Like, the people in power know how to use the process in order to deflect and defer movements. How do we make sure that what we're asking them, how do we keep that eye on them to make sure that what they're passing is what they say they're doing and what we want?
By keeping that eye on them, you know, one thing is if you start developing relationships with the staffers of members of Congress, you know, if you can find sympathetic staffers, then you will get access, you know, to what they're writing, or at least if you don't get to see the text, you know, they'll fill you in on kind of on what it is. But, you know, it does take just, you know, keeping your eye on what's being said, on, you know, getting information any way that you can. I think, you know, one way that we actually got a meeting with Sanders' top staffers about the legislation that he was introducing back in 2017 is because I had kind of heard through the grapevine some of the things that were in it. And when we contacted his office, they weren't responding to me. He has a new staffer. I used to work with his health staff, but he had a new staffer who was very difficult. And so I wrote an article saying, hey, these are the things we hear in the Sanders bill, and this is why they're bad, and got it published. And next thing I knew, I got a phone call that he was royally pissed off about that. And I was like, well, you know, they wanted to meet with me. And I was like, well, I'll be there at this time. And they're like, okay, we'll meet you at that time. Did it end up having an impact on the final legislation? No, he did everything that we didn't want him to do. He sacrificed what should have been in the bill in order to get people like Cory Booker to sign on to it. But I think if there had been more folks who were holding that line and, you know, complaining, that, you know, we could have had more of an impact. But yeah, you just have to keep calling them out. And, you know, like when we were fighting during the TPP fight, we ended up taking over a space on Capitol Hill for 3 weeks and having a presence there 24/7. And we had pieces of paper with the different positions of the different members of Congress so that anybody who walked by could see. And it was amazing to me that literally members of Congress would come out to look and see where they were on the, you know, which piece of paper we had them on, and they'd be like, wait, but I should be on this one, you know, and they would send staffers down as well to talk with us. So anything that you can do to be like saying, hey, you know, they're passing this healthcare system and we understand there's a big loophole that's going to keep the private insurance going, you know, this is not okay. Just keep exposing it and pressuring it.
So there's a great question here in the chat. Yeah, let me read this question. So per your analogy about the Democratic Party used public option to divide and defeat Medicare for all in 2009, which Biden just repeated again in the campaign, And now we have Biden shoveling more billions yet again to the health insurance companies, to the health insurance gougers. Sorry. Why are you optimistic? The current Democratic Party has shown no political will to buck their donors, and the squad won't even use its political capital to fight for it. So why are you optimistic?
Because I've never thought that we were going to win this by just the Democrats giving it to us. They're just not. They're a capitalist party. I'm excited because of kind of the new energy I see coming in, the growing support for it, and I see it as an environment in which we could organize and win, but only if we have this understanding. And I think the fact that the Democrats, that Biden has come out opposed to it, that the Democrats have like the squad refused to support the force the vote. And unfortunately, it was actually some established single payer groups that gave them the political cover to do that. And that pissed off a lot of folks that are not part of that established. I can tell you there's a lot of conversation going on within the single payer movement right now about that. So I see it as an environment, especially with the recession and pandemic, that this is a reasonable demand, and it's a great opportunity for organizing. But again, it's going to take doing the work.
Excellent. I think that we are getting close to the time where we would be done with the questions. But let me see if Norman has a.
Yeah, Norman makes a good point. Yeah, the Democratic Party has been pushed every time to put this into their platform, and they don't do it.
Yeah, and I think that so I guess the question is, where you're optimistic now, you think that the climate is better. What should we do? What should we take away from here and go do tomorrow and the next day and the next day in order to help push this so that we can make it a reality?
Well, I think everybody can do something just by educating yourself and talking to others around you, and just really advocating for it every opportunity that you get to kind of spread the word. But I think we could, as a Green Party, if we wanted to decide to do some more activities around this, we could do that. There are a lot of groups that are kind of advocating for this. And we're looking at reviving the HOPE campaign, which is a Health Over Profit for Everyone campaign that we actually had direct action camps and did kind of direct action through that. So, but unfortunately in Maryland, there is kind of a group through like Progressive Maryland that's trying to push for state legislation. And I think it's unfortunate that they've gone in that direction, but there are also a lot of folks through the Medicare, the Healthcare is a Human Right campaign, we've been clear for a while that our fight is for national improved Medicare for all. So, there are other folks in Maryland to reach out to and work together on this.
Let's take this as the last question. Has the movement considered that a major impediment to bringing about national improved Medicare for all is the political, social, and racial divisions that we have in our country? When half of the country literally hates the other half and doesn't care if they die, they have little incentive to push for a single payer system that helps everyone. In what ways can this movement bring people together who mistrust or despise each other?
That's a great question. First off, if you look at the general trend of polling numbers over the years, we're seeing higher support even among conservatives for national improved Medicare for all. So that's a good thing, because the way that we win campaigns is you don't have to have everybody fighting for it. You need to have a supermajority of the public supportive of it, and then you need to have a minority of the public that's mobilized and actively working on winning it. But I know through experience, and there's folks in the single payer movement that are conservative folks, and we've put together even like how to talk to conservatives about national improved Medicare for all. I think when you sit down one-on-one, and I found this during my campaign too, when I was running for Senate and I was calling people, and a lot of times the homes I would call, it was actually a son or a daughter that was the green, and they weren't at home anymore, but I would reach the parent. And then we'd have these conversations, and sometimes, they'd ask me what I was running on, and we'd talk about Medicare for All. And it's amazing when you talk to people one-on-one and you start to really kind of they just don't know it. They don't hear these things. And once they do, it's such a, it's just such a common sense solution that, you'll be surprised. I even had Republican members of Congress I talked to that have said, hey, I get it. This makes the most sense, but my constituency, is totally in this different headspace. And, so I think that one, we don't need everyone on board to win, but I think that, just reaching out to people where they are and talking to them. And even if you don't convince them that time, I always think of it as planting seeds. We're just trying to plant as many seeds because you never know. And I've seen this happen where somebody's been exposed to the idea and then something happens in their life. They can't afford their medicine. Something happens to a loved one. And finally, they understand why we were talking about what we're talking about, why we say that we need a different system. So
I know I said that was the last one, but there's one more that came in from Facebook. And that is, how can we transfer the knowledge of functioning universal healthcare system throughout the EU to the American electorate?
There are different systems in the EU, but I think it's hard to compare some of those to the United States because the way they have been used is to try to convince people that we don't need national improved Medicare for all. They'll say well, why don't we do the German system where they have private health insurance, but not recognizing that the whole history of the German system came out of the late 1800s and their whole guild system, and it's private insurance in Germany is a completely different type of beast than what we have in the United States. And we can't turn our private insurance companies into what they have in Germany. They're just polar opposites. So I think that we have in the United States a VA system and a traditional Medicare system. So we have a public, completely socialized system, and we have a public finance private delivery system through Medicare. And I think just looking at those and saying, let's have a debate about which of these systems in the US work better. I just find the European stuff gets very confusing because there's a lot of different ways that they run their systems. And also people often turn to Switzerland, another private insurance based system, but Switzerland, people the per capita income in Switzerland is really different from here in the United States. It's just a really different economic situation that allows them to be able to have a fairly decent system, although it's not as good as the pure single payer ones, in Switzerland. So I don't know. I guess that's my thoughts on kind of that.
So thank you so much, Margaret. This has been really informative and has really helped to answer a lot of questions. I thought the Q&A was great. I thought there were great questions from the audience, and I thought that the answers really laid a path forward. And I think hopefully provided some people an opportunity to think that this is a fight that we can fight for and win. Is there anything you want to say in closing before we wrap up and hand it over to Ashley for a couple of closing remarks?
Oh, thanks. Yeah, no, just if you have other questions, feel free to reach out to me, and or if you need resources, need to be pointed to resources, just reach out to me anytime. I'm happy to respond to you. Excellent.
Thank you very much, Margaret. It's been a pleasure to be able to have this conversation with you tonight. We really appreciate the opportunity. Ashley, can you come on and close us out and let folks know how they can support the great work that the Baltimore City Green Party is doing?
Sure. Hi, everybody. Thank you, everybody, for coming, and everybody that was watching on the Facebook. If you'd like to donate or find out how to become a member of the local party so that we can build and support these efforts, I'm going to put the link in the chat. You can go to baltimoregreens.com and stay tuned for future membership meetings and more speaker series.
Great. Thank you, Ashley. Thank you, everybody who tuned in. Thank you, Andrew, for running the tech tonight. And thank you, Margaret, for providing us some amazing information, some inspiration, and some knowledge that we can use in the fight in order to make a more just and humane system for all of us. The healthcare is a fundamental human right, and the Green Party has been fighting for it for decades. We know that this is a fight that we can win, and we know that with your help and your support, we can keep pushing these issues and we can keep following that ICU model that Margaret put out. Thank you all so much. It's been wonderful. We look forward to doing the next one, and have a good night.